No responses. Hello. Dr. Victoria, hello.
Hi, Dr.
Hello. What about your progress?
So I'm done with embryology, anatomy, physiology, and currently on pathology.
And what was your scores in every block?
Um, I did okay. So for embryology, it was good.
Mhm.
It was good, and physio was also. They were all pass marks. I- I'd like to use the word pass mark,
Okay,
but
that's
I
it.
can send them to you if you want me to.
Okay, you can just send it to me. Where is Dr. Oksana? Why are we getting so less students in the group day by day? One or two students are they're just not coming. Okay. Anyways, let's start our session today, right? So today we are going to cover a lot of things. We are going to start from here, cardiomyopathy, right? And the other day we are going to do these things. All of these are memory. We have to memorize it. These things are going to be done in the next lecture. Today I want to start from cardiomyopathy and just try to do as much as possible, right? So we'll be directly starting from a first aid. I'm going to write down here things, right? Word by word, we are going to discuss first aid, right? What is cardiomyopathy? Do you guys know what is cardiomyopathy?
Yeah,
Yes.
it's diseases of the heart's muscles.
Okay, cardiomyopathy. Cardio for heart, myo for muscle, pathy for pathology, right? So it's
Yeah,
going to be pathology of cardiac muscles. Okay. So the first one which we are going to discuss is dilated cardiomyopathy. What is dilated cardiomyopathy? It's again going to be pathology of heart muscles which lead to dilated heart.
yes.
Okay. How can we get dilated heart? Okay, let's discuss it. Let's do it from our
Mhm.
first day, right? So the most common cardiomyopathy is going to be dilated cardiomyopathy. Really important. Remember that it's really important, right? Okay. So the first one is idiopathic or familial due to mutation of TTN gene encoding for sarcomere titin, right? We know that cardiac muscles are basically made up of you have actin and myosin filaments, right? So for example, if these are the actin filament, myosin filament, actin filament, and myosin filament. So in the end, you have a protein which is called as titin protein, right? Titin protein. And how to remember what's the function of titin protein? Titin protein keeps your heart tight. Okay. So the gene which encodes for titin protein is going to be your TTN gene. So it's easy to remember. What's the function of TTN gene? To encode titin. What's the function of titin? It tightens your heart. So for example, if we have any mutation leading to loss of titin protein, TTN gene, titin protein, so the heart is not going to be tight. And the heart is not tight, it would become loose. Am I right? And as the heart become loose, it's going to lead to dilated cardiomyopathy. Does that make sense?
Yes.
Right? Dilated cardiomyopathy. This is going to be one of your UWorld MCQ as well, right? So it's a familial or idiopathic, it's something related with gene mutations, genetics, right? So you have to keep that in mind. Similarly, certain drugs like alcohol, cocaine, and doxorubicin, right, which is your an anti-cancer drug, it can also lead to dilated cardiomyopathy. Keep these drugs in mind. Coxsackie B virus, viral infection of your myocardium leading to myocarditis, can also lead to dilated cardiomyopathy. And Chagas disease. Do you guys know what is Chagas disease? Chagas disease. Anyone? Hello? Are you guys doing the microbiology in parallel with these systems or not? Hello? Hello, 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 hello.
Hi, yes, Dr. Ahmed. Are you hearing me?
Yes, I can hear you.
Yeah, so Chagas disease is like an infection. It's caused by a parasite, Trypanosoma cruzi. and
Okay.
is infected. You get it from, I think it's like the bug is, I don't know the actual name of it, but it's called
Fine.
the kissing bug.
Yes.
Okay. Okay. So it's a bug, Trypanosoma cruzi, right? And it can lead to dilated cardiomyopathy. Specifically, the apex of the heart is going to become dilated. This portion of the heart is going to lead to dilate, dilation, right? So Chagas disease itself can lead to dilated cardiomyopathy, right? Similarly, ischemia as well. If we have coronary artery disease and it lead to, we discussed it already, right? It lead to any like infarction of any part of your heart, any muscles. So what would happen as a result of that? We are going to be having fibrosis, and we discuss it can lead to a pseudoaneurysm as well. So if we have an aneurysm there, you know, fibrosis is going to replace the heart. It's again going to be dilated cardiomyopathy, right? It's a pathology of heart muscles which is dilated. Am I right? Hello?
Hello.
Yes.
Yes. Similarly, hemochromatosis. So, what is hemochromatosis? We discussed, right? Hemochromatosis is a condition in which the body is going to reabsorb a lot of iron, right? That iron is going to deposit in different tissues in different structure. It can also get deposit in the heart as well. But once it deposits in the heart, initially it would lead to restrictive cardiomyopathy. Keep that in mind, right? Like your heart is going to be restricted towards filling, but with time, when it progressive to a chronic pathology, chronic deposition of iron there in the heart, it would lead to dilated cardiomyopathy, right?
Oh,
Hello, is it
yeah,
clear?
it
Peri-
is.
Hello, peripartum, right? After, you are going to be having something called postpartum cardiomyopathy as well, right? Postpartum cardiomyopathy. So right after a mother give birth to a baby, so sometimes we can have some autoantibodies which can cross react with the heart, and it can lead to dilated cardiomyopathy. That's very important as well, right? Hello.
Hello.
Okay.
Yes.
What else can lead to dilated cardiomyopathy? Here it's mentioned wet beriberi. Do you guys know what is beriberi? Hello? Hello?
It's a
Yes,
wet
I
and
think,
dry, yes.
It's going to be thiamine deficiency, vitamin
yeah,
B1
timing.
deficiency, right? Vitamin B1 or thiamine deficiency. If we have time, okay, so we have two variants of beriberi, right? Dry and wet. What do you mean by dry and what do you mean by wet? Do you guys have any idea?
I think dry is predominantly neurological. It has more neurological manifestations, and then wet is cardiac.
Yes, perfect. So what happened in dry beriberi, that it's mainly going to affect your nervous system, right? And we are going to also be having peripheral neuropathy, right? Like we are going to be having symmetrical peripheral neuropathy. What do we mean by symmetrical? On both sides, the nerves are going to become degenerated, right? We are going to be having not neuropathy. Muscle weakness and muscle wasting is also going to be seen. So if your nerves are affected, you're also going to be having loss of reflexes, right? Because we discussed, and we'll be discussing in the neuro section as well, that the nerves are okay. We discussed it in MSK. If you guys remember the patellar reflex, remember which nerve is going to be involved in the patellar reflex? Femoral nerve, right? Hello. So if we have neuropathy, so it's also going to lead to loss of reflexes, right? Especially in the legs, the patellar reflex won't be there, right? Similarly, it can lead to foot drop and wrist drop as well because the nerves are going to be affected more. While in case of wet beriberi, the cardiovascular system is going to be affected, right? Like we can have congestive heart failure initially, we can have tachycardia, palpitation. It can lead to dilated cardiomyopathy. Is it clear? So dry beriberi and wet beriberi. Is it clear? Yes or no?
Yes, it is.
Thyrotoxicosis as well. What is thyrotoxicosis? Yes. Hello. What is thyrotoxicosis? We did it in embryo in endo.
I think it's when you have too much of thyroid hormone, like excess thyroid hormone.
Huh?
I think that's what it is. I'm not sure.
Okay. Okay. So actually, thyrotoxicosis, whenever we have excess thyroid hormone, T3 and T4. So let's move towards the basic physiology or basic effect of T3 and T4. What is the effect of T3 and T4 on our body?
So I think T3 is the active form, and then T4 is inactive, right? Um, so you know what? Yeah.
So what is the function of T3, the active form?
It controls your body metabolism and like your energy balance.
Sorry,
Okay.
can you say again, doctors?
What's the function of T3 and T4? We discussed that T3 is basically the potent form of thyroid hormone. We know that it would increase the basal metabolic rate, if you know, right? That is, it
Mhm.
would increase the activity of your NAK plus pumps, right? So as they are pumps, they use a lot of ATP. So the ATP consumption is going to be increased. But along with that, it's also going to increase the beta adrenergic receptors activity in your heart as well. Increase sympathetic nervous system activity, right? Like, for example, in case of hyperthyroidism, an individual is going to appear with tremors, he's going to be having palpitation, tachycardia, right? So sympathetic activity is also going to be increased in hyperthyroidism or thyrotoxicosis, in which we have you know, a lot of T3 and T4, right? So what would happen as a result of thyrotoxicosis on heart, increased amount of T3 and T4 can lead to structural remodeling, right? As you know that the heart is going to be pumping more, a lot of blood. Heart is going to experience a lot of blood. So can I say that the heart is going to be, just like if it's, more of blood is entering into the heart and heart is just pumping a lot in order to get rid of that blood. So the heart is going to be in, volume overload state, right? Volume
Yes.
overload state. And as we discuss what happens in volume overload state, the heart is going to undergo which hypertrophy?
Dilated.
Eccentric hypertrophy, remember?
Eccentric. It's a habit.
Right? Yes, if it's eccentric, so the cavity size of the left ventricle basically increases. We discussed it, right? So
Yes.
in the end, it's going to lead to dilated cardiomyopathy if it remains for chronic period of time, right?
Tigmaca.
Is it clear?
Yes.
Okay, let me just erase it. Okay. So it's really important to know. Similarly, it can, the T3 and T4 can lead to arrhythmias as well, especially like we discussed that atrial fibrillation, right? It can also lead to atrial fibrillation. There we discussed that. Okay. So you can see, okay, what are going to be the finding in the end? Heart is going to fail. We are going to be having S3 heart sound. Why? Remember what was S3 heart sound? The early passive filling, right?
Yes.
Early passive filling. If you have dilated heart, a lot of volume in the heart. So what would happen? The blood is going to splash here. It's going to hit that big surface of the left ventricle, and as a result of that, what would happen? It's going to lead to S3 heart sound, which is early diastolic heart sound. Remember?
Yes.
Okay. Okay. So we are going to be having systolic regurgitant murmur. Why? Yes.
Because of too much blood.
Okay. The idea is really same. For example, if this is your normal heart and this is your mitral valve, right? So if the heart become dilated, so you can see these mitral cusps would move apart from one another, and now it isn't able to close properly. Heart valves, mitral valve won't be able to close properly. So during systole, some blood is going to enter into left atrium, which is going to give you systolic regurgitant murmur. What was the murmur associated with mitral prolapse or mitral regurgitation? That was, yes.
I don't understand your question. Okay, you said one murmur is associated with
Yes,
I-
which murmur
I
is
was confused.
okay? For example, if this is your normal heart, right?
mhm.
The mitral valve can close properly. Okay. If the same heart get dilated, in dilated cardiomyopathy. So you can see the heart valves are going to move apart from one another, right? Hello?
Yes.
These
Yes.
valves are going to move apart from one another. And as they move apart from one another, they cannot close properly. And whenever a valve cannot close properly, it would lead to regurgitation. Right? Hello?
Yes.
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 Means mitral regurgitation, that is during systole, some of the blood is going to regurgitate back into left atrium. Am I right?
Yes.
Okay, so as the blood regurgitates back into left atrium, it's going to be a regurgitant murmur. Which murmur? That's a hollow systolic murmur, right?
Hollow systolic flow.
Okay.
Yep.
Okay. So you can see here. Okay, just give me a second. Okay. So we know we are going to be having eccentric hypertrophy, right? In athlete's heart. Why? Because again, in athlete's heart, the heart is going to deal with a lot of blood. It's going to be a kind of volume overloaded state in the heart. And as we have volume overloaded state, in order to compensate that, we are going to have eccentric hypertrophy. We know that, right? Where the left ventricle end enlarges and it would facilitate the increased stroke volume and cardiac output. We have something called stress cardiomyopathy. What do you mean by stress cardiomyopathy? It's also called as Takotsubo cardiomyopathy. So in the U world, you will be having an MCQ. They are going to tell you that we have a female and her husband died. She was really sad all the time, and after some time, she had a heart failure. She died. What do you think? What happened? So that was due to dilated cardiomyopathy, right? So due to a lot of norepinephrine and epinephrine release during stress, it can lead to structural remodeling within the heart, which can lead to dilated cardiomyopathy, also known as broken heart syndrome. Is it clear? Okay.
Yes. bro.
Okay. Why do we call it Takotsubo? Takotsubo basically mean octopus-like, right? Okay. So the heart apical portion is going to lead to ballooning, a big apical portion, just like that. It will just seem like an octopus, right? So octopus is just like that, right? Okay. Okay. Due to increased sympathetic stimulation in a stressful situation. Is it clear?
Yes.
Yes, it is.
So
the
is it
treatment- Mhm.
you said this is broken heart syndrome,
Yeah.
right? As a
Broken.
result of stress and increased sympathetic stimulation.
Yes, increased sympathetic stimulation in a stressful situation would lead to dilated cardiomyopathy. Is it clear?
Yes, it is.
So the fine. Okay, what is going to be the treatment? Sodium restriction. Why? Because the heart is already dilated, it's already in a volume overload state. So Na basically is a good osmol which catches water with itself, right? Which can further worsen the situation by having a lot of water. Since your heart cannot bear a lot of water, a lot of extracellular fluid volume, or a lot of blood, and so Na restriction is going to be the first thing which you should just keep in mind. Is inhibited in ARBSY in order to decrease the level of aldosterone. And what's the function of aldosterone? Aldosterone itself reabsorbs Na along with water, H2O, right? Sorry. Okay, so volume overload, if you're just, we have to give ACE inhibitors or ARBS to avoid the volume overload or stress on the heart, right? Similarly, beta blockers can be given. Why? We don't need the heart to pump more, to work more, because already it's a dilated cardiomyopathy, it's a pathology. So we would just slow down the activity of heart in order to avoid heart failure, right? Sacubitril. Remember what was sacubitril? Sacubitril, we did it.
Neprilysin inhibitor.
Neprilysin inhibitor. What was the function of neprilysin? They basically degrades your ANP and BNP, right? And BNP. So if you are giving neprilysin, it would inhibit, very sorry, it would inhibit neprilysin. If neprilysin is inhibited, we are going to be having a lot of ANP and BNP. So a lot of ANP and BNP are going to, they are basically atrial natriuretic peptide. They are going to move, or they are going to eliminate the sodium out of your body. And as the sodium is eliminating out of your body, water is also going to be eliminated out, which is going to be a helpful step for your dilated cardiomyopathy, since heart is already dilated, having a lot of blood volume. Is it clear? Hello?
Yes, it is.
Are
Yes,
you
hello.
guys able to understand or not? Hello?
Yeah,
Yes.
it's clear.
Okay, that's great. Oh, great. Okay. Diuretics. We are going to give loop diuretics, thiazide diuretics again in order to remove the extra volume out of your body, right? Mineralocorticoid receptor again is used to eliminate the heart, and in the end, we can do heart transplantation, right? Is it clear? Hello?
Yes.
Yeah.
Okay, so it was all about dilated cardiomyopathy. Any questions? Hello?
Hello,
Okay.
you're here.
Okay. Next one, which we are going to discuss, is hypertrophic obstructive cardiomyopathy or hypertrophic cardiomyopathy. What happens in hypertrophic, as the name indicates, the heart is going to undergo excessive hypertrophy, but that is going to be a pathological hypertrophy. Normally, we discuss we can have concentric hypertrophy whenever we have hypertension. It's going to lead to a lot of muscles within the heart, concentric hypertrophy. But when the same hypertrophy get pathological due to certain pathology, it's going to be hypertrophic cardiomyopathy. Like for example, it's going to be a condition, a familial condition, autosomal dominant condition in which we'll be having mutation in two things. Remember one of your U1 MCQ: myosin binding protein C and beta myosin heavy chain. And as we get mutation, okay, they basically make your heart muscles cardiac myocyte. As we get mutation there, so the heart is going to become excessively hypertrophic. Even the interventricular septum is going to become hypertrophic. So that's really important to know. If the interventricular septum become hypertrophy, so it's going to be your hypertrophic obstructive cardiomyopathy, right? And it's the most common cause of death in young athletes. Why? Okay, first of all, if you have concentric hypertrophy, which heart sound is going to be associated with concentric hypertrophy, stiffened heart? Remember, it's going to be an early diastolic or late diastolic sound.
Great diastolic.
S4 heart sound. We did it right. Remember? Hello? Hello?
Yes, doctor.
We did it right. S4 heart sound. Did you guys
Yes.
remember? So S4 was basically your atria contracting again, stiffened ventricle. And since we have hypertrophy, it's a stiffened ventricle, right? So we are going to be having S4 heart sound. Why do it lead to death in young athletes? That's really important to know, right? So whenever in this case, if we have excessive hypertrophy, right? So what happens that whenever your heart is contracting, so you can see, okay, this is your metal cusp. So and this is your aorta. You guys know that, right? Aorta just exit from the heart just like that, right? Your aorta and pulmonary artery like that. So once the heart is contracting, so this hypertrophied part and the mitral valve cusp are going to functionally obstruct the aorta. It's not an obvious obstruction, but as the activity of heart increases, as we are having a lot of contraction of the heart, these parts are going to come and they are going to block your aorta, right? And the blood won't move into aorta. If the blood isn't moving through the aorta due to hypertrophied interventricular septum and mitral valve cusp coming, in the path of your aorta, and blood cannot move up, it can lead to decreased blood moving out into the aorta, into the brain, and suddenly it can lead to death. Is it clear? So we do not have obvious obstruction, but we have a functional obstruction. What do we mean by functional obstruction? As we're increasing the activity of heart, these two parts just come close to one another and they would obstruct the aorta. So it's going to be aortic stenosis kind of situation. Is it clear? Hello?
Yes, it is.
Okay. And as we have excessive hypertrophy, so the electrical activity of the heart is also going to become disrupted, which can lead to arrhythmias as well, right? So you guys can see cause syncope during exercise. Why? During exercise, okay, this is your U1 MCQ. Which part of the heart leads to obstruction? Some part of your interventricular septum and tricuspid valve cusp are going to obstruct the aorta. Blood cannot move into the aorta, not reaching the brain. It can lead to syncope. Does that make sense?
Yes.
Okay, and may lead to sudden cardiac death in young athletes due to ventricular arrhythmia. Why? Because as you have excessive hypertrophy, the electrical, activity or the electrical pathway in the heart is going to become disrupted, which is going to lead to ventricular arrhythmia. As it played, findings are going to be as for heart sound. We know that it's going to be systolic murmur. The murmur is going to be same as that of aortic stenosis. Which murmur was associated with aortic stenosis? Yes. Yes. I think you guys aren't revising what we did. Hello. 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 Hello.
Is it hold?
Is it? I think it's
Is it
Chris-
hold systolic? I'm not
I
sure.
think no, it's crescendo, decrescendo for aortic stenosis. I think.
Let's just see. You guys aren't revising. I understand that today, and that's really bad. We
I
did
think
it.
it's yeah, it's a crescendo, decrescendo.
Crescendo, decrescendo, right? So the murmur is going to be, just like it's going to be a systolic murmur because the aortic stenosis murmur occurs in the systole, right? So it's going to be a systolic murmur. You guys can see it here, right? Okay, may see mitral regurgitation due to impaired mitral valve closure as well. So we can also have mitral regurgitation as well. Why? Due to excessive hypertrophy, as I already told you, this mitral valve cusp is going to obstruct the aorta, and it can also lead to insufficiency or improper closure of mitral valve as well, which can lead to mitral regurgitation. Is it clear? Hello?
Yes, it is.
Okay. So we have ventricular concentric hypertrophy, as we discussed. Sarcomere are added in parallel. We know that in case of eccentric, sarcomeres are added in series, while in case of concentric, sarcomeres are added in parallel, right? So open septal predominance. Often the interventricular septum is going to undergo hypertrophy. You guys can see this is the same picture which the UWorld is going to give you, and they're going to ask you what's happening. So you can see this interventricular, this septum, it's so hypertrophy, right? Okay,
Yep, it is.
so we can have classified as hypertrophic obstructive cardiomyopathy. Hypertrophy is going to lead to functional obstruction of aorta. Can I say that?
Yes, you can.
Yes. So what does function? Okay, so this hypertrophy is going to lead to functional obstruction, as we discussed. Okay. Okay, what else? It's also going to lead to asymmetrical septal hypertrophy, as we already discussed, and systolic anterior motion of mitral valve, as we already discussed. So outflow obstruction is going to lead to dyspnea and possible syncope, right? So as you have obstruction here, it's going to lead to syncope. Blood cannot move out into the aorta. Brain would just, the blood is going to reach the brain. Less blood is going to reach the brain, which is going to lead to syncope. And along with that, we have stenosis, so blood can also back up, right? Can back up in the pulmonary system, which can in the end lead to, yes, dyspnea, right? Pulmonary edema, we know that. Is it clear? Hello, guys, why aren't you responding?
Can you take it again? It's, like some of them are confusing though. For me, I don't know about other people.
Yes, just please
I
tell
don't
me.
want to say yes when I really don't understand it, right? That's why I'm quiet sometimes. So can you take this one last time, please?
Okay, can you just tell me which point shall I repeat again? This entire topic? Hello, hello, hello.
Hello. Sorry, I didn't know I was still on mute.
Okay. For example, if this is your heart, right? And okay, this is someone's heart, not your, okay? Okay, and we have hypertrophic obstructive cardiomyopathy. What happens in hypertrophic obstructive cardiomyopathy? It's a genetic condition which would lead to excessive concentric hypertrophy, right? A lot
Yeah.
of muscle are going to be laid within the heart, right? Even the interventricular septum is going to become harder too. Is it clear?
Yes, it is.
Okay, and these are your mitral valve, leaflet, or cusps, right? So as the heart is contracting, just like that, what would happen? You know, this part of interventricular, okay, this is your aorta. We know that it's your aorta, right? Aorta just move out from the heart just like that. Am I right?
Yes.
Okay. So as we are having heart contraction, so this part of interventricular septum and mitral valve cusp are going to come close to one another. And as they come close to one another, you can see it's a kind of aortic stenosis. Can the blood move out?
No.
No. And if in young athlete they have hypertrophic obstructive cardiomyopathy, we would advise them not to run, not to have more exercise, right? Because
Yeah.
it can lead to functional obstruction of aorta, which can lead to syncope, right? That is, the blood won't reach the brain if we have less blood moving out into the aorta, right?
Yes.
Okay. What else would happen here? We know that a lot of sarcomeres are being laid down, right? So it would disrupt the electrical activity of heart. And as the electrical activity of the heart is disrupted, it would lead to, different arrhythmias. Is it clear?
It is clear. It's better. Yes.
Okay, fine.
Thank you.
Okay. So this was all about hypertrophic obstructive cardiomyopathy. That's a simpler concept. Let's just discuss it from here. So we can see we have septal hypertrophy, we have outflow obstruction, dyspnea, and possible syncope. We know that. Okay. Is it clear? Shall I just move forward?
Yes. For me.
Okay.
Yes.
So what's going to be the treatment? Beta blockers, calcium channel blockers. Why? In order to decrease the heart activity, because as we are increasing the heart activity, it would lead to, okay, let me just ask you another question. If we have a murmur, right? We have murmur due to functional obstruction in hypertrophic obstructive cardiomyopathy. Which manures would lead to decreased intensity of murmur? What do you guys think?
Waggle.
Okay. Yes. Okay, let me just ask you. Okay, let me just ask you some question. What would leg raise manure do to the intensity of murmur in Hawkon?
It will increase, right?
Why?
Like, because there will be increased cardiac
Blood.
rhythm.
Increase
There will
blood
be
volume.
increased
Blood
blood
volume.
to the heart.
Okay. So if we are having less leg raise manure, what happens to the preload as we already discussed?
It will increase.
Preload would increase. Preload, if increase, it means it means a lot of blood is going to be present within the left ventricle, right?
Yes.
Yes.
It means that the left ventricle, okay. So if a lot of blood is present, it means that this interventricular septum and the mitral valves cusp are going to move apart from one another. Am I right?
Mm-hmm.
Yes.
I think if they are moving apart from one another, the intensity should decrease. Why? If they are moving apart from one another, you guys can see it here. If they are moving apart from one another, it means that now we will be having less chances of functional obstruction during every contraction.
Yes.
Yes.
So any manures which leads to increased blood within the left ventricular chamber would decrease the intensity of murmur. So what would hand grip manure do to the murmur intensity? Yes, what would hand grip manure do to the murmur intensity?
It will decrease murmur intensity.
Why?
I think it's the same mechanism as leg raise because you know,
Perfect. We are in leg raise manual, we're increasing the afterload. If we are increasing afterload, so the blood won't leave the heart. Again, it's going to lead to a lot of blood within the heart, which is going to lead to, you know, interventricular septum and middle valve cusps are going to move apart from one another, which is going to decrease the intensity of murmur. Is it clear?
Yes.
Okay. Okay. So let's just discuss it here. So beta blockers, non-dihydropyridine, all of them decrease the activity of heart, and it would decrease the functional obstruction, right? Verapamil, we are going to discuss it in pharmacology, and in some cases, cessation of high intensity athletics. We know that. Okay, the ICD. What is ICD? ICD is basically implantable cardioventer. Okay, that is cardioverter defibrillator, right? ICD. And what's the function of ICD? ICD is basically, you can simply think of that it basically is an implantable device which decreases, the sudden cardiac death due to tachycardia or any arrhythmia, right? So it would decreases the chances of arrhythmia. And as we discussed, we can also have arrhythmia in hypertrophic obstructive cardiomyopathy due to a lot of hypertrophy disrupting the electrical activity of heart. Is it clear? Avoid drug that decreases preload like diuretic and vasodilator. Why? Now you guys know that. Hello.
Increase the volume.
It would decrease the volume, and as the volume is decreasing, so this interventricular septum and the cusp are going to move close to one another, and as they move close to one another, now there would be increased chances of getting, yes, now there would be increased chances of getting functional obstruction and worsening the murmur, leading to a lot of syncope and everything. Is it clear?
Mm-hmm.
Yes,
Okay.
it is.
So the next topic which we are going to discuss is restrictive or infiltrative cardiomyopathy. What do you mean by restrictive cardiomyopathy? If this is your heart, something would happen as we discuss in hemochromatosis initially is going to lead to restrictive cardiomyopathy. A lot of iron is going to restrict the heart towards filling. As you guys know, we did restrictive lung diseases, right? There we discussed due to fibrosis, the lungs are going to be restricted towards filling. So same is the case here in restrictive cardiomyopathy due to hemochromatosis, sarcoidosis. What was sarcoidosis? Do you guys remember? The non-caseating granulomas. Remember?
Yes.
They can enter into the heart, enter into the skin, a lot of places, which can lead to, okay, a lot of sarcoidosis, non-caseating granulomas can lead to it can restrict the heart towards filling, right? Amyloidosis as well. If the amyloid get deposited within the heart, so it would lead to, yes, yes, please.
It's it's just fibrils gonna build up like the extra tissues.
Yes. So
Yeah.
it's basically disorganized kind of proteins, right?
Mhm.
Which is going to lead to deposition in different body parts. It can lead to deposition of amyloid, which is disorganized beta pleated sheath and sheath, which we'll be discussing in detail in our general pathology. Is going to lead to. Okay, so let's just do it amyloidosis, right? Because this amyloidosis concept keeps on repeating again and again, right? In a
Yeah.
lot of systems, right? So let's do amyloidosis. Okay, from trachoma.
Mm-hmm.
It's your systemic amyloidosis. So what is
Yeah.
amyloidosis? You can see here, right? It's the
Yeah.
amyloid deposition in multiple organs. What is amyloid? Okay, so you can see it's divided into primary and secondary amyloidosis, right?
Yeah.
So the primary is basically systemic deposition of amyloid, which is derived from immunoglobulin light chain. Did you guys remember something from multiple myeloma?
Yeah, it's abnormal proteins.
Yeah, so we discussed in multiple myeloma, that's basically a plasma cell dyscrasia cancer, which is going to lead to a lot of antibodies. Antibodies have heavy chain, they have light chain. The light chain sometimes can build a lot and they can deposit in different tissues, which can lead to amyloidosis, right? The
Yes.
secondary amyloidosis is AA amyloidosis, which is derived from serum amyloid associated protein, right? So SAA, what is SAA? Yes, it's basically an acute phase reactant, right? Which is going to be seen in chronic inflammatory states. We know that whenever we have chronic inflammatory state, it's going to lead to production of immune acute phase reactants. If you guys remember from immunology, which interleukin was responsible for the release of acute phase reactants? Interleukin 6. Remember? it?
Yeah.
Yes.
Super acute.
Yes. Okay. So acute phase reactant and its increase in chronic inflammatory, which can lead to amyloidosis, right?
Mhm.
Similarly, FMF. What is FMF? That's familial Mediterranean fever, right? Which we are
Yeah.
going to discuss in detail, right? It can also lead to amyloid. Amyloid is basically, here you can see, it's a misfolded protein that deposit in extracellular space, right? So the multiple protein can be beta pleated sheet configuration. What do you mean by beta pleated sheet? It's a disorganized kind of protein. So any disorganized kind of protein, whenever it deposits in different structures, are it's basically called as amyloidosis. If you guys remember, we discussed dialysis related amyloidosis. Remember, it was due to deposition of what? Carpal tunnel syndrome, MSK. Those who took the lectures know that.
Oh yes.
Dialysis related amyloidosis. Dr. Victoria, yes, please.
I think as a result of beta 2 immunoglobulin not being it's not filtered, right?
Mhm. The MHC class 2 have beta 2 globulin.
Yes.
Beta 2 globulin cannot be filtered. It can lead to a lot of beta 2 globulin in the blood, which can deposit in different tissues, amyloidosis, right? It
Yes,
can
that is
deposit in the flexor retinaculum, leading to carpal tunnel syndrome, right? So this was basically amyloidosis. So the
yeah.
simpler thing which you should just remember is it's a disorganized kind of protein which get deposited in the heart. So the heart would just become, it would get restricted towards filling, right? The
Yeah.
heart is going to become restricted towards filling, right?
Mhm.
Similarly, we have another thing that is endocardial fibroelastosis. What is endocardial fibroelastosis? As the name indicates, the endocardium is going to be filled with fibrous and elastic tissues, right? In young children. So if it become filled with fibrous tissues. Again, the heart is going to become restricted towards filling. Heart won't fill properly, right? Okay.
Yeah.
Post radiation fibrosis. If you are giving a radiation to an individual, let's suppose he's having any kind of breast cancer, lung cancer, radiation itself can lead to fibrosis within the heart. And as the heart become fibrous, can we fill the heart properly? No, it would lead to
No.
Yeah.
yes. Okay. So diastolic dysfunction is going to be seen. Why? Because heart is not filling properly. The filling phase is diastolic. So can I say diastolic dysfunction? Can have low voltage ECG despite thick myocardium, right?
Mhm.
Why are we going to have low voltage ECG? Just think on that. It's really simple. Low voltage ECG is also going to be
You see it in I think low voltage you have it in is it wait.
in tamponade, right?
Tamponade, yes. Yes. Pericardial effusion.
Here again, we are going to be having low voltage ECG because you can see that the heart is covered by, let's suppose, iron in hemochromatosis. It's having sarcoidosis in this case, having Loeffler endocarditis, which is going to be having a lot of hypereosinophilic syndrome, right? So what would happen? The electrical activity, how do we record ECG? ECG is recorded whenever the electrical impulses from the heart comes to the chest and we just place leads here, we just record it, right? So as you know, we have an extra medium present between the heart and chest. It would lead to decreased ECG. Like in tamponade, we have blood, right? So that blood could lead to decreased voltage being sensed by your heart or the chest. Is it clear? Yes or no? Hello?
Yes, it is.
Okay. So let's discuss our next topic, that is heart failure. What is heart failure? We know that. Okay. The heart would fail. Okay, we can have two kinds of heart failure, systolic and diastolic, right? So you can see when it's a systolic dysfunction, the heart isn't able to undergo systole, it's failed, it cannot pump blood outward, the blood is going to stay within the heart. It's a volume overload state. Will we be having eccentric hypertrophy? Yes or no?
Eccentric is in cardio megaly says no.
Okay. If we have a lot of volume overload state because heart is not pumping blood, right? A kind of dilated situation is going to be present because heart is going to be having a lot of blood. Which heart sound is going to be associated with volume overload state?
Sound 3, S3.
S3. Perfect. So you can see include S3 heart sound. Jugular venous distension. Why? Because the heart isn't able to pump blood. Blood is going to back up here in the lungs, back up here in the left atrium, in the left ventricle, back up in the jugular veins as well. As we discussed, both of them are in communication with one another. They do not have walls. JVP we discussed in detail, right? So the jugular veins are going to be distended. Is it clear? Pitting edema, because the blood is going to pool back in the veins as well. And as the blood pools back in the veins, there the hydrostatic pressure of the blood would increase, which would lead to edema, right? So it's going to be a pitting edema. Is it clear?
Mm-hmm.
Yeah.
Okay. What else? Okay, symptoms dyspnea. Why? Because we have pulmonary edema as well. Orthopnea, again, we have pulmonary edema as well because heart isn't pumping, pulling back of the blood. Systolic dysfunction is heart failure with reduced ejection fraction. Heart cannot undergo systole properly, right? So what would happen to end diastolic volume? It would increase. We know that contractility would decrease. Why? Because heart cannot have proper contraction, proper systole, right? It's going to be secondary due to ischemia, MI, or dilated cardiomyopathy. Is it clear?
Yes.
Okay. Like we have decompensated heart failure. Decompensated heart failure means that heart get failed without any compensation. Okay. We have diastolic dysfunction. What do we mean by diastolic dysfunction? Heart is able to undergo systole, but we are going to be having diastolic dysfunction. For example, if the heart become hypertrophied a lot, right? So the cavity size would decrease.
Yeah, decrease outflow.
Yes. So the blood, okay, the cavity size decreases mean the blood in the left ventricle is going to decrease because the cavity size is decreased. Am I right?
Yeah, decrease. Yeah, cardiac output.
Yes. So decreased cardiac output due to Frank-Starling mechanism, right?
Yeah.
So although the heart can pump blood, but very less amount of blood being pumped by the heart is also going to be really problematic, right? So we have preserved ejection fraction. Heart can contract, but decrease compliance. What do we mean by compliance? We discussed compliance is basically an ease of getting stretch, right? I've just
Yes.
made my own definition. How easy is it for the heart to stretch? So if we have a lot of muscles, it's really difficult for the heart to stretch, right?
Yes.
And if
Yeah.
it's easy, if it's easy to stretch, so the compliance would be more. But if it's difficult to stretch, the compliance would be less. So is it difficult to stretch the heart or easy to stretch the heart?
Right now it's low complicance.
Yes, because heart is going to have a lot of muscles. It's really hard for the heart to get stretched, to get filled with blood, right? So the compliance would decrease. Okay.
Yes.
Yes, it's going to be to myocardial hypertrophy.
And it means that the left ventricle and diastolic be increased, yeah, because
Yes.
that's gonna,
Yes.
it's less stroke volume.
Yes. Yes, that's right. Okay. So you can see that we can have right-sided heart failure as well, which result from left-sided heart failure. If the left side gets failed, it do not pump blood. The blood again is going to pool back. It's going to pool back within the lungs. It's going to pool back within the the right ventricle. It's going to pool back in the right atrium. Am I right?
Yes.
So can I say due to pooling of blood within the right ventricle, the right ventricle isn't able to pump blood because there is already a lot of blood, pulmonary edema due to pooling back of the blood. So in the end, the right side would also fail. So can I say due to left-sided heart failure, the right side can also fail?
Yes.
Yes.
Okay.
It is.
Yes. Okay. So that's really simple things, and you only have to focus on it. Okay. So what is core pulmonale? We discussed core pulmonale. Core pulmonale is basically isolated right-sided heart failure, right? So as we discussed that sometimes if we have a lot of, okay, let me just give you an example. If you have hypoxia, we know that the blood vessels within the lungs are going to be constricted, right?
Mm-hmm.
In our normal body, whenever we have hypoxia, it leads to dilation of blood vessels. But only in case of lungs, it would lead to constriction of your blood vessels. As the blood vessel get constricted, what would happen as a result of that? As a result of that, the afterload would going to be increased. The left ventricular afterload is going to increase, right? And as the left ventricular afterload increase, it would be really difficult for the left ventricle to pump blood out into pulmonary artery. That's simple. Is it clear? Hello?
Yeah.
Okay. So in the end, if we have this case, the right ventricle, sorry, can get fade, which is known as core pulmonale, right? Hello?
Yes.
Yes,
So
yes.
if we have heart failure, obviously we are going to give them ACE inhibitors because heart cannot pump blood out. So we don't need a lot of blood there, right? So give them ACE inhibitors, ARBs, angiotensin receptor blocker, neprilysin inhibitor, sacubitril, beta blocker because heart cannot pump a lot. You do not want the heart to get overloaded, right? Similarly, we can give aldosterone receptor antagonist, which can decrease the mortality, and thiazide diuretics. All of these drugs basically eliminate the extra cellular fluid volume, right? It would decrease the blood within the heart, and it can improve, or it would decrease the blood within the body, which is going to improve, which is going to decrease the stress on your heart, right? Because heart is failing, heart cannot pump blood, right? So
Yes.
you have to remove the stress. Hydralazine, what is hydralazine? And it's basically a vasodilator, right? So
Mm.
we are going to discuss that. Okay, SGLT2 inhibitors improve both symptoms and mortality in selected patient. What is SGLT2 inhibitor? What do you guys think? Flozin drugs, remember? Canagliflozin. Okay, so in the renal section, we discuss the SGLT2, that is sodium glucose co-transporters, right? So we have a channel that is SGLT2, and it basically reabsorbs your glucose, right? SGLT2 inhibitors are also one of the therapy for diabetes as well, right? So we are going to inhibit this channel. This channel won't reabsorb glucose, right? So it can help an individual diabetes, right? Because the diabetic condition is whenever we are having a lot of glucose in the blood, right? So I can give them SGLT2 inhibitor, right?
Mhm.
Hello? But remember, glucose is also a good osmol, right? Glucose love to keep water with itself. So as we are giving SGLT2, it can not only improve diabetes, but as the glucose is going to, move in the urine then if I'm just blocking this channel. Am I right? Hello?
Okay.
Okay, I think you guys didn't understand it. Okay. SGLT2. What is SGLT2? In your proximal convoluted tubule, simply you can imagine we have a channel or a pump or a transporter that is called as SGLT2. The function of SGLT2 is to reabsorb glucose into the blood. Is it clear?
Yes, that is fine.
Certain group of drugs, that is flozin drugs, would inhibit this channel, right? So as I'm inhibiting this channel, the glucose cannot enter into blood. It would be eliminated in urine. Am I right?
Yes.
So can
Yes.
I say, can flozin drugs improve diabetes?
Yes, it will. Yes. Yes.
Yes. But okay, in diabetes, an individual who is diabetic, they have polyuria. You know that, right? They urinate a lot.
Mhm.
Why?
Urea.
They have polyphagia. They just become, hungry a lot, right?
Yes.
The, yes.
Yeah.
Why?
Yeah.
Why are we going to have those polyuria? They're also having polydipsia as well. Why? Okay, let me just tell you. The polyphagia is okay. It's really conceptual thing. Just keep that in mind. Although we have a lot of glucose in the blood in case of diabetic patient, but the glucose cannot enter into the cells. Why? Because we do not have insulin. Am I right?
Yes.
Yeah.
Glucose is more, but you cannot utilize glucose. So can I say even though glucose is more, but the cells are hungry
Yeah.
because glucose cannot enter into the cell. Cell need glucose. We have a lot of glucose, but we do not have someone to push that glucose into the cells. So as the cells are hungry, individual is going to be hungry, right? It's going to lead to polyphagia. He's going to eat a lot. Does that make sense?
Yes, it was.
If we have a lot of glucose in the blood, it means lot of glucose is going to be lost in the urine as well, right?
Yes. Yes.
A lot of as and I just told you that glucose is basically osmotically active. So a lot of glucose in urine mean it would just pull a lot of water with itself in the urine as well, right?
Yes.
Yes.
So he will be having polyuria, a lot of urine. Does that make sense now?
Yes.
Why is he going to have polydipsia? Is he's losing a lot of water? He's going to be having more craving for water as well. So he's going to drink a lot of water, right?
Mm-hmm.
So if I'm giving Flozin drug, it means glucose cannot be reabsorbed. Glucose is going to move in the urine, right? And along with glucose moving in the urine, it would just pull off a lot of water with itself, right? So
Mhm.
giving Flozin drugs would not only improve the diabetes, but it would also lead to removal of water from your body, which your ACE inhibitors were doing, which your ARBS was doing, which your all of these drugs were doing, right? So can I say that SGLT2 inhibitors can also improve the symptoms of heart failure because we are removing extra or water from the body, which is going to decrease the stress on the heart because heart is failing.
Yes.
Does that make sense?
Mm-hmm.
Yes.
Myocardial infarction.
Okay. So this was all about heart failure, right? So we can have left heart failure. That's really simple. If the left heart get failed, blood is going to pool back in the heart, right? And again, the blood is going to pool back in the pulmonary system as well, right?
Yes.
And if you have a lot of blood in the pulmonary blood vessel, it would lead to edema, right? And as it lead to edema, it would lead to shortness of breath. Why? Because oxygen exchange won't occur if we have edema there, right? Am I right?
Yes.
What else? Increased venous return from redistribution of blood, immediate gravity, orthopnea. Why? Shortness of breath when supine. When an individual is supine, he's going to be having shortness of breath. Why? Because in supine position, lot of blood is going to, enter into the heart, into your upper extremities, which can worsen the pulmonary edema, right? So for
Yeah.
that reason, we basically have to keep 2 to 3 pillows to have an individual whose heart is failing in order to keep blood down in the lower extremities. We don't need blood in the upper extremities because as we have, it would just worsen the pulmonary edema leading to orthopnea, right?
Mm-hmm.
Hello? Paroxysmal nocturnal dyspnea. Breathlessness awaking from sleep. Why? Again, increased venous return would worsen the pulmonary edema, which would lead to shortness of breath. Pulmonary edema, as we discussed. Okay, so we are going to be having something called heart failure cells. What are heart failure cells? Remember, for example, if this is your left ventricle, blood is going to pool back into the pulmonary vessels, right? And as a
Yeah.
result of that, we'll be having pulmonary edema, right? Okay, in this pulmonary, okay, that's going to be a transudative edema or exudative edema.
Translative.
Transudative.
What do we
Transit.
mean by transudative? What do we mean by exudative? Whenever we have edema due to any bacteria, right? We know that whenever we have bacterial infection, it would lead to increased permeability, as we discussed in today's lecture in CNS, right? Remember?
Yes.
Yes.
we were having a lot of proteins whenever we were having pyogenic infection. Why? Because the bacteria makes certain toxin which increases the permeability, right? And as we are increasing the permeability, some blood cells can also move out from the blood vessels. Those blood cells are going to be eaten by the macrophages, right? The macrophages are going to eat those red blood cells. Red blood cells have iron, right? So these macrophages are also going to be called as,
Four
yes,
cells.
hemosiderin laden macrophages. What do you mean by hemosiderin? That the iron, which was basically prior the component of your red blood cells, are going to be now the component of your macrophages, right? So they are
Yeah.
called hemosiderin laden macrophages or heart failure cells. They basically appear, in imaging, they would appear like brownish in color. And we have lipofusion as well, which is also brownish. What is lipofusion? Hello. You know that the hemosiderin laden macrophages and lipofusion, both of them almost appear brownish in color. But the hemosiderin laden macrophages, you know that they are heart failure cells. They are going to eat the red blood cells, keep the iron with itself, leading to heart. But lipofusion is basically a wear and tear product, which is almost present in every individual as he ages. As an individual ages, we are going to be having oxidized, some oxidized components inside every tissue, which is known as lipofusion. That's a wear and tear product which can be present in every individual who is aging. Is it clear? Yes or no?
Yes, yes. Wear and tear.
Yes.
Yeah.
Okay. So we discussed it. Right-sided heart failure, we know that the central venous pressure is going to be increased. We know that. Increased resistance to the portal flow. We know that. Any questions here?
Yeah. What's backward failure?
Okay. If this is your heart, let me just tell you. Left heart get failed. It means blood is going to pool back. Am I right? Blood is
Yes.
going to pool back in the lungs as well. Blood is going to pool back in the right ventricle as well. Blood is going to pool back in the right atrium as well. Blood is going to pool up back in the jugular veins as well. Blood is going to pool back in the veins as well. And we know that the portal vein basically drains into, if this is your liver, into inferior vena cava. We know that. So the blood is also going to pool back in the portal system as well,
Yes.
right? So the liver can also become cirrhotic if the blood is pooling back. If you aren't draining blood out of the liver is going to become dysfunctional. It's going to be cirrhotic, right?
Yes.
And this case this is also known as nutmeg liver. Nutmeg liver, because the liver is only also going to appear just like a nutmeg. The outer portion of a nut. That's just like that. Okay.
Mhm.
Okay. Can I say due to right-sided heart failure, we can get nutmeg liver?
Yes. Yes.
Yes.
Yes.
Yeah. Right side failure. Yeah. This is the most reason.
So you can see congestive hepatomegaly, increased central venous pressure. What is central venous pressure? Pressure within the right atrium is also called as central venous pressure, as we discussed. Increased
Yeah.
resistance in the portal flow, we know that rarely lead to cardiac cirrhosis. Cardiac cirrhosis due to heart, liver becomes cirrhosis. Take nutmeg liver. Okay, jugular venous pressure is going to be more. Peripheral edema, increased venous pressure, which can lead to edema, pitting edema. Is it clear?
Yes. Yes.
Okay.
Yeah.
Okay. So so let's discuss our next topic, that is high output. Okay, what happens to my pants? Okay. High output heart failure. What do you mean by high output heart failure? Yes.
It's 1 second.
Just as
High
the name
output.
says.
It's just like when the cardiac output is higher, then
Okay, let me just tell you. Whenever we have
Volume.
whenever we have AV shunts, what are AV shunts? The arteries are directly connected with the veins. What happens to systemic vascular resistance in that case? Yes,
Increase.
It decreases.
decrease.
It
Because
decreases.
the arteries, whenever connected to veins, veins are really, distendable kind of structure. They can accept a lot of blood. So when the artery is directly connected with the veins, that's known as AV shunt, right? AV shunts or AV fistula, right? So what would happen? The systemic vascular resistance would decrease. Okay.
Ah,
So what would happen to the afterload?
Reduce.
We decrease.
Reduce. Perfect. Systemic vascular resistance decreases, afterload decreases, a lot of blood is entering into the veins. What would happen to the preload?
it's
Preload will increase.
Preload
elevated
would increase.
diastolic.
It will increase, yes.
It means that a lot of blood is entering into the heart and a lot of blood is moving out of the heart, because if the afterload decreases, we discuss cardiac output increases.
It's
Hello.
it's is it like elevated like diastolic pressure in the left ventricle?
Yes, we can say that, right?
Yeah,
A lot of
because
preload,
a
a
lot
lot
of
of
is
blood,
and a lot of is going out.
a lot of it's coming in and a lot of it's going out. Because the afterload is decreased, cardiac output will increase,
Yeah,
the preload is increased, right? So it's
yeah.
a high output. And as the heart is dealing with a lot of blood entering, a lot of blood moving out, it's going to lead to heart failure in the end, because your heart is pumping a lot, right? Its activity is a lot, right?
Mm-hmm.
Okay. So it's uncommon form of heart failure characterized by increased cardiac output. Systemic vascular resistance decreases due to vasodilation or AV fistula. Vasodilation itself can lead to decreased systemic vascular resistance, right?
Mm-hmm.
Causes include severe obesity, advanced cirrhosis, severe anemia, hyperthyroidism, wet beriberi. In all of these conditions I just told you, we are going to
Yes.
be having a lot of heart
Mhm.
is going to have a lot of blood. Paget disease of bone. Did you guys remember sarcoma as well? Which
Yes.
sarcoma? Yes, osteosarcoma plus AV fistulas or AV shunts formation. If those who have took the sessions of MSK, they better know it, right? Okay. So
Mm-hmm.
present with signs and symptoms of pulmonary and systemic venous congestions. Okay. As a lot of blood is flowing into the heart, a lot of blood is going to flow into the pulmonary system, a lot of blood is going to enter into systemic veins as well, because the preload is increasing, right? So it
Uh,
was, yes, please. Any questions?
yeah, it's I'm just trying to just like get it. Yeah, it means that like the cardiac output is higher than normal due to like increased peripheral pressure. Yeah,
The
because
cardiac output is more. Why? Because preload is more and afterload is less.
yeah, yeah, but because of like the peripheral, because the preload is depends of the peripheral.
Yes, problem is with the peripheral systems. You can say that peripheral formation of AV fistula, peripheral formation, hyperthyroidism. Yes, you can say that somehow.
Mm.
Correct.
Okay, thank you.
Okay. So it was all about today's session, and in the further 2 days we are going to finish this entire. Okay, so we only have these pages left for pathology, and we are going to finish it. Okay. Thank you so much.
Hi,
Uh,
Dr. Ahmed.
yes, please.
Could you please send the lecture because I'm on work and I'm listening. I can't see and I'm a visual person and I haven't been able to get the lectures to go over the stuff. So could you please send this lecture today because I really want to go over the things that you were saying.
Sure, I'll just send it once it just come to drive. I'll just send it. Okay.
Okay, and I can't participate as much because how I'm on work.
No problem. No problem.
Okay,
Okay.
thank you.
Thank you so much. Thank you, and see you tomorrow.
Thank you, doctor.
Thank you so
I'm
much,
also at
doctor.
work
Okay, no problem. I'll just send the recording. We are having so less participants. Why? I think I should
because
stop
we are at
recording.
work.
I think people at work, but I still tune in to listen. But most of us are here because I think it's like 10 people, 2, 4, 6. It has like 10 people before and then 9. So
No, we are two. We are two. Just we need
yeah, and that's 2. So that's like
also
before it had 11.
two devices. Sometimes we are using only one.
Okay, okay, that's good. Okay. Thank you so much. Thank you, and
Thank you.
Thank you. See you
Bye-bye.
tomorrow. Bye.
Bye.